I'd like to welcome everybody to the SUNY Downstate Alumni Association 2017 Reunion Scientific Session. I'm Jenny Libyan. I'm the class of 2001, and I'm proud to be chair of this session. I'm also a current Downstate faculty member, and I'm interim chair of pathology, and I teach our medical students almost every week. And one of my favorite things to do is make sure that they know about all the discoveries and achievements of our alumni, and they are numerous. And I can usually find something about almost every disease process. I'm therefore thrilled to hear from today's speakers, and they're all from major reunion classes, 35-year, 40-year, and 50-year. The topics this year are really of broad interest, and they're really all hot topics, often featured on the front page of the New York Times and also discussed by our politicians in Congress. The topics include football and traumatic brain injury, Lyme disease, the opioid epidemic, and overtreatment in psychiatry. I'd like to first welcome our president-elect, just voted in, Dr. Suzanne Mira, who's class of 1967, and SUNY Distinguished Service Professor, to introduce our first speaker.
Thank you, Jenny, and good morning. It is a pleasure to introduce our first speaker, my classmate and colleague, Dan Perl. Dan is a neuropathologist par excellence who has made major contributions to our understanding of neurodegenerative diseases such as Alzheimer's disease. As an aside, I have to tell you that in our graduating class at Downstate, it is amazing that 3 of us saw the light and went into careers in neuropathology. In addition to Dan and myself, the third was Nancy Siegel Perez, who was director of neuropathology at Stony Brook for many years before departing for Arizona. I just spoke to her last night, and she sends her warm regards to all. Why this cluster occurred is unknown, but it couldn't have hurt that we shared a wonderful teacher of neuropathology at Downstate, Dr. Stanley Aronson. In his illustrious career, Dan has focused on the role of environmental factors such as aluminum and neurodegenerative disease, such as the intriguing complex of amyotrophic lateral sclerosis, Parkinsonism, dementia complex among the natives of Guam. Hundreds of publications later, Dan has turned his attention to the effects of repeated head trauma, first working with colleagues in Boston to study chronic traumatic encephalopathy seen in former NFL football players and other athletes. But at a time when many of us have retired or are thinking about retiring, Dan has rejuvenated his career. After 24 years as director of neuropathology at Mount Sinai in New York, he joined the faculty of the Uniformed Services University of the Health Sciences in Bethesda to study the effects of yet another traumatic brain injury among military personnel who experienced shell shock or blast injuries. His findings have attracted much attention from fellow scientists, and not least from the media. Check out the New York Times Magazine, Public Television's newsletter, NewsHour, just to name a few. Today, Dan will share with us some of his exciting findings. Dan.
Well, thanks, Sue, and it's really a pleasure to be here and return to SUNY Downstate to talk about some of my work. Let's get it. So today we're going to talk about the effects of traumatic brain injury, both in the setting of contact sports, and then talk a bit about what's going on in the military in terms of on the battlefield. I have to start by giving you greetings from Washington. I'll try not to make any snide comments about what's going on there, but needless to say, I have to inform you that these are my own opinions and not those of the federal government or the Department of Defense, et cetera, and that I have no conflicts to report. We're talking about traumatic brain injury today, TBI, and I want to first let you know that this is a major public health issue to a degree that most people don't recognize. We're talking about at least 2.2 million emergency department visits annually, 280,000 admissions to hospital, and 52,000 deaths. Now, 52,000 deaths, how does that compare to some other public health issues that you hear about every day, that you see walkathons and telethons and things like that? Well, let's look at that. When we compare the 52,000 deaths related to TBI to colon cancer, it's 50,000. Breast cancer, 40,000 a year. Pancreatic cancer, 42,000. And influenza, 24,000. All right? It is estimated that there are 5.3 million Americans living with long-term disability related to prior TBI. 5.3 million Americans is equal to the current number of cases identified with Alzheimer's disease. So this is a huge issue that we really don't talk about, that is rarely, politicized in terms of NIH funding, things like that. And it just keeps going on and on each year. Now, as you know, in terms of our understanding of traumatic brain injury in the media, there's been an explosion in the last 10 years of coverage of the effects of repeated head injury in the setting of contact sports. Numerous stories in the New York Times, Time Magazine, Sports Illustrated, wherever you'd look, there are stories about this. Actually, this man in the middle is Alan Schwartz, who was a writer for the New York Times, wrote much of these stories, particularly in the early days, and really deserves a lot of credit for putting this on the map in terms of what was going on. It sort of culminated with the Hollywood movie Concussion. The idea that you would have a major Hollywood movie about what it is to be a neuropathologist and what neuropathologists do, played by Will Smith, come on now. How did that happen? So this is on everyone's minds in terms of what's going on, what is this all about, and in particular, what are some of the risks to not only these high-end professional athletes, but to the general population itself. It's a long story that I will synthesize in a few slides, starting with this man on the left, Harrison Martland, who is a medical examiner in Newark, New Jersey, interested in fights. It was sort of a hobby of his. He would go to fights. He knew people in the fight industry. We're talking about the 1920s, the heyday of boxing. He would hang around gyms and learned that there was a term in boxing called punch drunk, of boxers who had retired and would have this neurologic syndrome of aspects of Parkinsonism. They could become demented. And he said, my friends in medicine, they don't know anything about this. I'd like to introduce that. And he wrote a paper in the Journal of the AMA in 1928 describing it and saying, we should really study this. If this is really a disease, we ought to know something about it and put it in the textbooks. We know nothing about its pathology. Even though he's a pathologist, there's no pathology on the entity. But this is where it all started. Along the way, about 45 years later, Bennett Amalu, a trainee in neuropathology in Pittsburgh, described a single case of the same syndrome in a professional football player, Mike Webster, who played for the Pittsburgh Steelers. He called it chronic traumatic encephalopathy, or CTE, and that's the name that's sort of stuck, and that's where you'll hear it in the press and in the medical literature. This was followed on by the group at Boston University under Anne McKee, who's also a neuropathologist, and she started to collect a number of these cases and really set up a brain bank for former contact sport athletes, and began to see one after another cases, and now she has over 100 cases among professional sports athletes who have primarily been in contact sports. The nature of the disease, it's a progressive disease. It's a neurodegenerative disease related to the accumulation of a protein called tau in the brain. And you can see here all this brown is a stain for tau, and it's accumulating here, and we won't go into the anatomic details. I know you all remember them from your days at Downstate, but we'll leave that for another day. But here you can see these brown, what are called neurofibrillary tangles in the individual neurons, and as more and more neurons get involved, the case gets worse. You get more and more symptoms. And this progresses. It's a very unique pattern of distribution that can be recognized when you see the brain under the microscope. Virtually all of the cases with this pathology have been seen in individuals who've had experience with repeated head trauma. You don't see it by and large with a single head trauma. It's repeated head trauma, typically in the setting of participation in contact sports. And at the moment, it can only be diagnosed at autopsy with definitiveness. In terms of the clinical features of cases of autopsy-proven CTE, early in the course, you see headache, loss of attention and ability to concentrate, short-term memory problems, impulsivity, abrupt mood swings, substance abuse, very common, depression. So it's a combination of both neurologic and, if you will, behavioral or psychiatric aspects. In the later stages of the disease, as these patients get old, cognitive impairment to frank dementia and or Parkinsonism can be seen, but most of the cases die before they get to this stage. All right. Now, the media has just jumped with this, and there are numerous stories, and there's a lot out there in the media about this disease that really we need to stop and say, you know, what do we really know? What is evidence-based in terms of our real understanding and knowledge of this disease? So let's go through that and clear up some of the confusion. There's no currently available clinical diagnostic criteria of the disease. And so although you'll hear stories about so-and-so's got CTE still alive, but you know, what's that based on? We don't know until the person dies and the brain is examined. Okay? There's no scientific data available on the overall prevalence of CTE in the general population. Okay? Almost all of the cases have been seen among professional football players, professional hockey players, professional wrestlers, things like that. There are a few rare cases among college players and even a few among high school players, but by and large, those have been very slight involvement rather than the full-born disease. There's no clear concept of the dose of TBI needed to trigger CTE. In other words, how much of a head trauma do you need in order to trigger this tau accumulation? And there's been a lot of discussion about concussions, because concussions you can measure, you can count. You know, you'll hear so-and-so played football for 14 years and he remembered having 5 concussions. And yet when you look, there is no correlation between the number of concussions a player had in his career and whether they will develop CTE. And the importance of subconcussive blows is becoming increasingly important and increasingly discussed. Those are blows to the head that don't induce a true concussion, but they're still blows to the head, all right? And if that is true, okay, if subconcussive hits are as important as the concussive ones, then that has implications in terms of whether football remains a sport that we engage in, okay? Because football without subconcussive hits is not football, okay? The second important thing is the dose reached in recreational sporting activities? This is the soccer mom question. This is, my kid wants to go out for football or soccer. He's at risk for having a concussion. Is he at risk for developing this disease? Right? We don't know the answer to that. Okay? No one knows the answer to that. And it's an open question as to whether this kind of activity, this kind of recreational activity, is a true risk factor for developing this tau disease that we call CTE. Whether it has other features, other impact in terms of mental functioning, brain functioning, we'll leave for another day. But in terms of this illness, we don't know, okay? Important one, return to play guidelines. The return to play guidelines are, if you have a sports concussion, you wait a week asymptomatically before you can come back and play, okay? Rest the brain, okay? And every coach knows this. Every sports doc knows this. I mean, you have people walking up and down the sidelines from peewee to pro football. In pro football, they have guys in the upper stands looking down to see if somebody has a concussion. Get him off the field. He can't play until he's 1 week asymptomatic. Now, that rule, which is in place wherever you go, has no scientific basis in terms of preventing CTE. It might be helpful in preventing an additional concussion, but it has no scientific basis in terms of preventing tau accumulation. Nothing, okay? Where it came from, how it got cemented into our thinking, I don't know, but there it is. No effective therapy for this disease, and again, we don't know the biologic mechanism by which a blow to the head would trigger the onset of a neurodegenerative process such as a progressive accumulation of tau. We just don't understand it. All right. I'd like to switch gears now and talk a bit about TBI among the military, right? Of the military personnel, and of course our military is somewhat different than it used to be, and it's a volunteer, and they stay in for a career. But when they enlist, about at least 50% of military recruits have already experienced one TBI by the time they start their military career, okay? And then once they're in their career, about 80% of all TBIs that active duty service members experience occur off the battlefield, not in warfare. And what is that? It's civilian TBI. It's contact sports, it's motor vehicle accidents, they fall out of trees, they get into fights. I'll point out that currently at West Point and at the Naval Academy, boxing is a required sport. They must take it, and it's not a lecture course. Okay? So here's the official figures on number of TBIs in the 16 years we've been involved in the war on terror, since 2000 to almost today. And you'll see that they've counted 361,000 TBIs among military personnel. 82% of them, almost to 300,000, are considered mild. Now, what is considered mild among the military for a TBI? Well, if you look down here, see where it says LOC? LOC, that's loss of consciousness up to 30 minutes, is a mild TBI to the military, okay? Up to 30 minutes. Now, the other interesting thing about this chart is these are individuals who've had a TBI. So if you're in the military and you have a TBI and then you get a second TBI, you don't get it, there isn't an additional number here. These are just individuals who've had a TBI, whether it's 1 or 150, okay? So you start to get an idea on the extent of the problem, and everybody in the military admits that this is an underestimate, because there's lack of reporting of these. In the same way there was lack of reporting in the NFL and those sorts of things, okay? Now, we talked about the sort of military experience with TBI being very much like civilian TBI, but there's one aspect of it that's very unique, and that's unique to military, and that's our interaction with this weapon of choice of the enemy, and that's the improvised explosive device, or IED. It's the weapon of choice of the enemy. It's inexpensive to build. You don't need sophisticated technology. Little training to build one. Basically, you take artillery shells and you typically strap them together. You get a detonator and you bury it in the roadway and you wait for the enemy to come by, and then you push the button, and off it goes. It's very powerful, very effective, particularly with a remote detonation. Around 2006, remote detonators came into being so that you didn't have to have direct connection between you and the IED. You could stand there on the side of the road, push a button on your cell phone, and boom, it goes off, okay? And so you could build really big ones, and you could really target them. And it's responsible for at least 60, it's probably closer to 70% of all battlefield casualties are related to these IEDs. Now, you've heard about IEDs, but I want to show you what an IED looks like. Okay? Come on now. All right. You see a group of trucks coming down the road here. There are 4 trucks. They bunch up a little here at the corner. Watch the front truck. Keep your eye on the front truck. There we go. Okay? That's an IED. That's what our troops are up against. You see there are about 14 people in the trucks. Okay? Want to guess how many people died in what you just saw? 1. 1. Okay? Now, the question is, what happens to the rest of them? Okay? What are the effects of being in an incident like that, particularly on the brain, and surviving? Okay? So you need to know something about high explosives. High explosives are a unique type of explosive, very powerful, and in particular, they give off their energy in a very short interval. And because of that, they produce what's called a blast wave. And you can see it at the edge of these slow motion pictures of high explosives going off. That's the blast wave here. See it coming out? And the blast wave is a pulse of high pressure, 10 milliseconds, that goes out in all directions at the speed of greater than the speed of sound. All right? And when it interacts with the head, you can measure the blast wave entering the skull and passing through the brain. Okay? So we have a high pressure, very short high pressure pulse going through one of the most delicate and exquisite objects in the world, namely the human brain. Would it, wouldn't surprise you that that might cause some damage? Yes. Okay. So, a significant percentage of individuals who have experienced these high explosives end up with persistent symptoms related to their blast exposure. And here are some of them. They get headaches, nausea, vomiting, dizziness, blurred vision, sleep disturbance, very common, very disturbing, sensitivity to light and noise, balance problems, hearing loss, tinnitus. They get cognitive problems, impaired attention, problems with concentration and recent memory. They have a slowing of the processing of thoughts. They have poor judgment, disturbed executive function, and many behavioral problems, including depression, anxiety, agitation, irritability, impulsivity, and aggression. Okay, and these continue. All right, they come on almost instantaneously within a few days of the blast exposure, and they continue. Right, and the question has been for many years, what is the nature of this? Okay, now you'll notice many of those features overlap with what I described in CTE, but many of them overlap as well with another condition we'll talk something about, namely post-traumatic stress disorder, or PTSD. If you take such a patient with these persistent symptoms after blast and you put them in a MRI imaging instrument, you don't see anything, okay? Brain looks normal. And because of this, this had become known as the invisible wound. Namely, the impression was that the brain perhaps had been wounded by the blast, but there was nothing to see on the imaging study. We have to go back to World War I for the beginnings of our thoughts on this problem. because World War I was the first time high explosives was used in warfare, and they were used extensively in the trench warfare on the Western Front of World War I. Here's Dr. Frederick Mott, who was a neurologist, neuropathologist in that era. And in 1916, he published a series of papers in which he examined 3 cases of immediate death following being next to high explosive exposure. He described the focal hemorrhages in the brain, but more importantly, later on in these papers, he hypothesized that a condition called shell shock, which was a poorly described clinical syndrome of persistent neurologic and behavioral symptoms seen in thousands of World War I subjects, might be due to physical damage in the brain caused by blast exposure. Okay? He laid it all out. Never really got to study it. Okay? Now, subsequently, particularly because of the overlap in the symptoms between CTE and what we were seeing in our service members, some studies were done more recently to look for CTE among military service members who had been exposed to blast. Amalo, again, the guy who described Mike Webster, published a single case in 2011 of CTE following deployment in Iraq. Subsequently, the group in BU described 4 cases of CTE among veterans. One of the problems had been that many of these veterans had played contact sports, had multiple civilian-type injuries, and there was a question of what was doing what. A group at Johns Hopkins looked at 6 cases, and they said, we don't see any tau pathology, we don't see any CTE, but we see injury to axons. So that's sort of what had been done at that point. And by then, I was at Uniformed Services University, had built up a facility to do this sort of thing, and in partnership with the Joint Pathology Center, what used to be the Armed Forces Institute of Pathology, and the Maryland Brain Bank, we put together a series of brains to look at this issue in detail. And this is the paper we report with our findings, and I just want to show you some of what that is, okay? Our index case was this one, a 45-year-old Special Forces combatant who died at age 45 of suicide. He had served in Desert Storm, Iraq, Afghanistan, where he's considered to be highly competent, reliable, and emotionally stable. This was a real war hero, an amazing man. In combat and training exercises, he had been exposed to numerous blasts at close proximity. The effects of those episodes were not disclosed to his superiors because he didn't want to be deemed unfit for duty. It's the same as the quarterback who wants to play in the championship game. He just didn't want them to know. But once he was separated from the military, he complained of persistent headaches, sleep disturbance, memory problems, and trouble maintaining mental focus. He lost coherence of thought and had jumbled speech. His wife confirmed short-term memory problems and cognitive and behavioral changes. Following discharge from the service, he was worked up by 2 different institutions. They described poor eye contact, flat affect, and a low voice tone, certainly something that you don't see in Special Ops Forces individuals. And they treated him for his mental health problems. He was diagnosed with PTSD, depression, and anxiety. Now, I don't want to turn you into neuropathologist here, but let me show you. This is a stain for brain scarring. We're not looking at tau here, we're looking at brain scarring, astroglial scarring. Wherever you see brown, that's scarring. This is impact TBI with survival matching to the case we just described. And you can see all the scarring here that is occurring in this brain that is not seen in impact TBI, okay? It occurs in a very specific pattern in the brain that when we described it and it was heard by people who study blast biophysics, they said, this is exactly what we would have predicted from what we know about blast biophysics. So this was our first case. This was the index case, and we actually collected 5 chronic cases. They all looked alike. They all had the same pattern of damage. When we looked at impact TBI with no blast, we did not see it. These are at the same magnification, same staining. Again, we're looking at brain scarring. Many of the chronic blast cases had chronic substance abuse. If we looked at people who had no blast exposure but had chronic substance abuse, they didn't have it. All right? All of our 5 chronic blast cases had been diagnosed with PTSD and were being treated with PTSD, for PTSD. Okay? And we certainly didn't see it in impact TBI, substance abuse, or in cases of CTE. This gives you some idea on the dramatic difference between impact TBI and blast TBI. We're actually just looking at the slides without a microscope, and you can see all the scarring that occurs. We did look for tau in our cases, and in 2 of the cases we did find some tau. It's very minimal. This is about all we see. This is the most extensive involvement. The 2 cases that showed tau of the 5 chronic cases were the oldest and had the longest interval between their experience, their exposure to blast, and their death. And so we think that there's a long latency that takes place in terms of it, but this may be a second process that's taking place long after their military experience. And this is sort of the way we're looking at it. Here, time going on, before they get to the military, they have civilian TBIs. Once in the military, they get the civilian type of TBIs, the fights, the falls, and things like that. But then somewhere along, they get hit with a blast of significant power, producing some PTSD-like symptoms, and the immediate astroglial scarring, which is the brain just trying to heal what the blast wave passing through it has done. Okay? It's a static lesion. It's not going to progress. It's like an appendectomy scar, if you will. Later on, years later, we think that they are at risk for triggering this neurodegenerative disease involving tau and have both the scarring and CTE. What percentage are going to do this and develop this, we don't know. Obviously, we have a lot of work to do. These findings really changed the whole field very dramatically. No one was thinking in these terms, in terms of the nature of this problem. We still can only diagnose this lesion at autopsy. We're trying to see if we can find it by neuroimaging using really the highest techniques we can. So far we haven't, but I think that's going to be solved in the next few years. We don't know how common it is among active duty and veteran service members. It is possible that we're talking about hundreds of thousands of individuals, because we know that that's the kinds of numbers of who have been exposed to blast. What dose of exposure is required to produce it? Do multiple smaller doses equal a single larger dose? We don't know. What role does it play in the high risk of blast-exposed service members developing PTSD and other cognitive issues? We're well on our way to developing an animal model, and that's very important, and we're excited by this preliminary work. And obviously, we need to devise new ways of trying to prevent this, whether this is helmet design or body armor, things like that, and even treatment strategies. 100 years ago, Major Frederick Mott raised the possibility of damage to the brain by high explosives could possibly cause organic disease, namely shell shock. Okay? This we refer to in the lab as the Mott hypothesis. And many of the issues blast-exposed service members are currently struggling with may not strictly be related to their mental health problems. Symptomatic blast-exposed service members diagnosed with PTSD may have distinctive microscopic brain abnormalities not seen by MRI. That the presence of these abnormalities can contribute to both the neurologic and behavioral symptoms exhibited by these patients, and the approaches to treatment and diagnosis of infected individuals now need to consider these new findings that we've just described to you and have published, okay? Sadly, the war to end all wars did not accomplish the goal of ending war. We continue to struggle with the long-term effects of military TBI. This problem will undoubtedly be encountered in the future, and hopefully our ongoing studies will provide avenues towards dealing with these difficult and lasting consequences of participation in warfare. I need to stop and also remind you that blast TBI is no longer a strictly military issue. With the episodes such as the bombing of the Alfred Murrah building in Oklahoma City, the Boston Marathon, recent attacks in Paris, Brussels, St. Petersburg, and I could go on, but terror. The long-term effects of blast TBI are no longer strictly a military issue. Increasing numbers of civilians are also being exposed to these terrible weapons. And finally, before ending, I think we need to pause and thank the service members and their families who've agreed to donate the brain to our repository that we have in Bethesda. Without this precious gift, we could not do our research. We get to talk to these families, and each one is another tragedy, and they're really amazing families and amazing people. Our donor families often express the feeling that although their loved one has made the ultimate sacrifice through brain donation, they continue to serve their country. And we're pleased to know that this has provided considerable comfort to them. And then finally, I need to acknowledge numerous individuals who've done a lot of this work and helped us and supported our efforts, and most of them are listed here. And I thank you for your attention, and we'll take your questions. Yes, Bill.
One, which is a far greater number actually, athletics, and then you have the blast. That you would think that soccer, because there's more participants in soccer around the world than there is in football. Second of all, is that it's a daily contact with the head virtually every practice. So you would think that professional soccer players should have a much larger number of them potentially being able to be studied for tau.
Right. It's certainly been seen in professional soccer players. I've seen, I think, 4 cases in professional soccer players. Part of the problem is that these cases are seen because you have a soccer player who's died, whose behavior has been abnormal. The family is interested in checking to see whether they've got CTE, and so they donate the brain. We need to have a much more broader, non-biased, if you will, selection in order to see what percentage of, if you will, professional soccer players or even football players have this problem. And so far, that has not happened. Okay?
The problem is that we're so lagged so far behind in soccer versus all the other countries, say in Europe.
Sure.
So are there studies going on in Europe which would, obviously be far more important than, you'd have to go another 20, 30 years before we'd have potential pathology that they already have in Europe.
Yeah. Is this me? Oh, my God. Oh. I know in Europe they're studying rugby players. I'm not sure there's a formal study of soccer players in Europe. I can certainly find out. This is not easy work to do because you're talking about relatively young, relatively healthy people, and the death rate is relatively small. When we were doing all this Alzheimer work, Sue was doing it, I was doing it, and you're talking with 80-year-olds, death rate is huge, and it's easy to collect brains. When you're talking about 30-year-olds, the death rate is quite small, and so it's much harder work to do. But I think, there's a huge NCAA study in which they're studying soccer players, football players, and controls, trying to make that, get some of those numbers. But, gee, by the time they get the numbers for that, because they need autopsies, I'm not sure, most of us are going to be around, frankly. Yeah. Yes, Roy.
One of the issues it raises is what lines of research are being pursued in the world of imaging?
Great question, Roy. Imaging is an evolving field. The magnets get stronger, and they devise newer and newer means of looking at, now white matter tracks and things we never dreamed of in terms of what they can image now. By and large, no one has been able to diagnose either CTE or this astroglial lesion using at least routine imaging studies, and we've actually taken cases among the military where we suspect this guy must have it, kind of thing, and put them in the 7T scanner at NIH and some of the other really fancy ones, and so far we haven't seen anything, all right? There are some clues from some particular approaches in terms of handling the data, the sequences, those sorts of things, particularly at the University of Washington, that seems to be picking up something, mostly in the posterior fossa, interestingly enough, that may be seeing this lesion. It's still a little early. Somebody's going to pick up something and be able to identify it, and that's going to be a very important day because we don't need to wait for autopsies once we have that. We're actually supporting some of that research work. There's a fair approach in terms of using PET scanning, particularly for CTE with tau tracers, which are coming online now, and a flurry of papers have come out. Nothing's really ready for prime time yet. Our astroglial lesion will require developing a whole new set of PET tracers, and people are starting to talk about doing that. It's one of the sort of game changers that this research has produced.
Time for one more question, and then there'll be time to ask questions after.
I'll be around, don't worry. Yes, sir.
You mentioned Alzheimer's disease.
Yes.
Are you or others looking at genetic risk factors such as apolipoprotein E in either form of the
Right.
traumatic brain injuries?
Right. When you look at CTE, there seems to be, at least in some studies, a slight tendency for the E4 allele for developing CTE, although it's not strong, and some studies have failed to find it. So it's a little unclear. We haven't had enough diagnosed cases of the astroglial lesion. I mean, it's less than a year old, to address that. Knowing what I know about ApoE, I suspect it's not going to be related, but obviously we need to do, genome-wide screen to see if there are other underlying genetic risk factors that might be important in terms of who's going to develop this. Sorry.
In full disclosure, I'm also a neuropathologist, so you have three of us here. I'm also a soccer mom, and the younger kids, they stopped heading, but my older daughter heads, and every time I see the soccer ball go to her head, I see a tangle forming in